Often Physician Reviews Neurology Review Session for Step 1. The next section will cover reflexes, proprioception, and pain. The most important reflex that you need to know about for Step 1 and for later in clinical practice is the stretch reflex. This is also referred to as the deep tendon reflex, although all we're using the tendon for is to stretch the muscle. So this is really a muscle stretch reflex that we're talking about here. Let's look about what happens here. We use a reflex hammer and we tap the tendon of the patella, for example. So if we tap that, it actually stretches the quadriceps muscle. And the muscle spindle within that quadriceps muscle will detect that stretch. Next, the mechanical signal is changed to an electrical signal. So ion channels on intrafusal fibers within the muscle spindle will be stretched and those ion channels will open. Once those ion channels open, it changes the electrical signal that is within the nerve, and that will send a signal, an action potential, back to the dorsal root via 1A fibers. This is a very fast conducting fiber. At that point, the synapse occurs with the motor neuron of the ventral horn. So this is a monosynaptic stretch reflex where the fiber goes through 1A fibers and synapses on the ventral horn, and then that neuron will send a signal out to contract the quadriceps muscle. So you can also see other important features of this monosynaptic stretch reflex, and that is that you may have also some inhibitory interneurons which can relax the antagonist muscle to the one that you're actually stretching. So this is the whole complex set of events that occurs when you tap on a reflex. So primarily you'll get activation of the muscle that's stretched and some of its agonists or synergists, but you'll also get relaxation of some of the antagonists of those muscles when you do a tap the tendon. Now, here is also a way to remember what areas of the body or what areas of the cord that you're actually stimulating when you do a reflex. So a tendon reflex of the ankle will primarily get S2. And there's some, you might say S1, S2, but let's just use the round S2 as our suggestion here. So also, if you tap the knee, you're going to get L4. If you tap the bicep, you're going to have C6, and if you tap the tricep, you're going to be testing C8. So one way to remember that, and the reason why we say approximately 2, 4, 6, or 8, is because it goes very nicely, and you can remember ankle 2, knee 4, bicep 6, tricep 8. So 2, 4, 6, 8. But remember, it's approximate. Okay, so while we're at it, we'll talk about decorticate and decerebrate reflexes. This is primarily important just to be able to recognize in the clinical setting. In the hospital, you may have a patient with severe brain damage, and if you give them any pain in the distal extremities, they may withdraw, but it may not be a purposeful withdrawal. So you need to be able to look at what type of movements the patient's having and determine whether they may be having decorticate or decerebrate posturing. One way to remember it is that decorticate posturing causes the person to flex their arms and flex their biceps, which could make something that looks like an O with their arms. So you would say decorticate posturing. Okay? Whereas also there's decerebrate posturing where they would extend their arms and extend their wrists, and that's called decerebrate posturing. Now, a simple way to remember it is that these lesions are related to how high up in the brain the damage has occurred. The primary delineator is what, as they say, the red nucleus. So if the lesion is above the red nucleus, let's say lost my cortex, I may have decorticate posturing. But if the lesion is below the red nucleus, maybe I lost my cerebrum, my entire cerebrum, then you would get decerebrate posturing. So that's a very oversimplification of it, but it's a good way to remember it for the boards, I would think. What other sensory systems we need to talk about? Well, let's really make sure that we have the pathways of proprioception and pain and temperature down, because these are very high yield pathways. As you can see on this slide, the importance of proprioception is that we test it in vibration and proprioception. We test it with by wiggling the patient's toes and determining whether they can tell us which direction we wiggled the toes. That information enters in through the dorsal root. The first order neuron is sitting in the dorsal root ganglion. That information enters the dorsal root and ascends via the fasciculus cuneatus or gracilis. If it's in the lower extremity, it'd be gracilis. If it's in the upper extremity, it'd be cuneatus. That information then synapses in nucleus gracilis or cuneatus. That would be where the second order neuron is, and it's sitting at the lower medulla. Then the information crosses to the other side and ascends via the medial lemniscus into the thalamus. And this particular nucleus where it synapses is the ventral posterior lateral nucleus. And from there, that third order neuron sends its information up to the postcentral gyrus, to the primary sensory cortex. That is the entire proprioceptive pathway. Pain perception is pretty much similar except for what happens in the cord. Information from pain does have its first order neuron in the dorsal root ganglion, just like for the dorsal column system. This is going to be subserved, however, by the anterolateral or spinothalamic system. So as soon as it goes into the cord, it's going to synapse in the dorsal horn and then cross over to the other side, where it will ascend in the spinothalamic tract. It will ascend through the brainstem without doing anything special and end in the thalamus, where it synapses in VPL. VPL will send, that's where the third order neuron is, that will send its fibers up to the postcentral gyrus. So the first order neuron for the pain perception pathway is in the dorsal root ganglion. The second order neuron is sitting in the dorsal horn in the substantia gelatinosa. And the third order neuron is in the ventral posterior lateral nucleus of the thalamus. So both systems, both pain and proprioception, have first order neurons in the dorsal root ganglion and third order neurons in the ventral posterior lateral system, or ventral posterior lateral nucleus. The difference occurs when you look at the second order neuron. The pain perception pathway has its second order neuron in the dorsal horn of the spinal cord, and the proprioception pathway, the dorsal column / medial lemniscus system, has its second order neuron sitting in the lower brainstem in nucleus cuneatus or gracilis. This concludes our section on pain and proprioception as well as reflexes.